everyone, and welcome to the FAFP conference call with our president, Dr. John Gross, who will be discussing direct primary care, a primer. I want to go ahead and give an introduction for Dr. Gross. Dr. Gross, obviously, everyone knows he is the FAFP current president and a well-established and highly respected physician in the Tampa Bay area for more than 13 years. Dr. Gross is considered a leader in both the medical and civic community who practices compassion, ethical, and effective medicine. So this evening, we are honored to have Dr. Gross, FAFP president, on our call, and I'd like to go ahead and turn it over to you.
Great. Thank you very much for the introduction. Compliments will get you everywhere. So, and I wanted to say thank you to everyone that's on the call for spending your time, your evenings. Evenings are very valuable, and so don't think it's not lost on me that you're spending time with me. So, and so I'm talking to you about direct primary care, and or as you can see there, how I learned to stop worrying and love family medicine for real. And I'm sure that if you're on this call and you're here for this presentation, you've done some research, you've read about this, at least your interest is piqued, and hopefully you get a little bit more direction and insight on DPC from what I have to say about it. So I'm just going to go ahead and start. Now, are all of you residents? Let me ask that question before no. Some of you are students as well. Some of you are attendings. No, some of you are I see some head shaking and whatnot. Yeah, just wanted to get a feel, like if it's mostly residents or all students, although I got the gist earlier that it was going to be mostly residents. So let's get this out of the way quickly. There's going to be questions. And so every couple slides, I'll stop and look in the question chat box and answer it that way. I think that's going to be, I think most of us have been on enough Zoom calls and Microsoft Teams to know that it's kind of hard to ask those questions on the fly. So, but I will promise to stop every once in a while and take a look at the chat board there. All right. So disclosures and credits and acknowledgements. There's no financial to disclose, although I am taking applications. So you just send me a message if you have any money to give me later. So Rebecca Bernard is a doctor that, if you've done any DPC, especially in this area, she has been one of the trailblazers, and I have stolen is too strong a word, borrowed heavily from her presentations on what DPC is about, and then of course I put my own spin on it. Douglas Farrago, no one cares. Oh wait, hold on, there we go. Douglas Farrago is also a DPC doc that wrote a book called The Official Guide to Starting Your Own Primary Care Practice. I have no financial ties to him, but doggone it, that book isn't fantastic as far as, if you're in the pre-planning stages of going into DPC, it is a must read in my opinion. And so a lot of the things that I say are going to be echoed there. Atlas MD is the EMR that I use for my DPC practice. And I actually cannot say enough about it. Again, I have no financial involvement in that, but I'll never love an EMR, but for goodness sake, it is very supportive. You can't beat its customer service. They have a lawyer on standby to ask about legal issues. I mean, it's like their Facebook group is actually, and Twitter, they're actually responsive. And so a lot of what I learned about DPC, as far as from a practical standpoint, I learned from Atlas MD. So I have an NDA. So I was previously employed, as you'll find out, and that's a non-disclosure agreement. So that means I can't say non-factual opinions and bad things about my former employer. And so that is a disclosure. And so I have to say that. And here's the other disclosure. Let's be real here. I'm 8 months in. So I think I know what I'm doing. I'm doing my best. And so you're going to get a lot of my impression of how my practice is doing 8 months in. The fact of the matter is that the the community is actually pretty large nationwide and very supportive. You know, I had a lawyer friend say to me once, "You doctors are crazy. You guys share intellectual capital freely without any kind of expectation of being paid." I'm like, yeah, we're like that. Same kind of concept when it comes to DPC practices that are getting started, even around in my own town of St. Petersburg, Florida. It's been good to connect with other DPC guys and share ideas. And then the last thing is, man, I keep on losing. Google Images. I can't say enough about Google Images because, for goodness sake, I use them all the time. And so I don't think they get enough acknowledgement. So this is a loosey-goosey talk, by the way. Like, it's going to be relatively, if you guys were expecting like a very formal presentation, unbutton the top button on your shirt collar, because it's going to be fine. All right, so a little bit about me. So this is where I'm like kind of immodest and just tell you where I'm coming from. So I went to WashU for undergrad. I went to the Ohio State University College of Medicine. There I graduated A-OK, as opposed to some of my friends that were, AOA. I was fine with that. I did my residency at Bayfront here in St. Pete, family medicine, then Bayfront, the sports medicine fellowship. So I'm board certified in both family medicine and sports medicine, because that's where I wanted my practice to be. The great thing about family medicine is that it is very malleable and you can make it into what you want. I am not huge on geriatrics, and so I kind of moved over towards sports medicine, which has a less of a geriatric population. However, I do have patients in my practice that, are 72 years old and doing Ironman. So, but that's perfect for me. That's great for me. So I'm the team physician for the Tampa Bay Rays, and that's awesome. I'm gonna take two seconds to talk about that. People say it all the time. How did you become the team doctor at Tampa Bay Rays? I showed up. Half of life is showing up, as someone once said to me. And so, I asked. All they can say is no, and I'm calling security. They said okay, and I showed up. So, and I've been the team doc for the Rays for 4 seasons now. I was assistant for 11 seasons prior to that. I was a medical director for Ironman Florida for 10 years, and I'm currently the medical director for the St. Anthony's Triathlon. The point is, I work with a lot of athletes, and you'll see how this ties into a DPC practice later, in that it won't be just one faucet that the flow of patients is going to come out of. It's going to come out of a number of them. I'm currently the president of the Florida Academy, as if that wasn't obvious. And the story behind the story there is that I always thought it was important to be involved with the parent organization of your specialty. And what you're seeing today is 18 years, I guess. Yeah, 18 years of being involved with my state organization. And you stick around long enough, they make you president, turns out. So I kid. And then I was an employee physician for 13 years. I was with the same organization. And then from there, I decided to go into DPC. So as my mom said, when I, graduated from residency, do you have a job yet? I have only had one job, and this is my second job. So it's exciting. I'm also fantastic in golf scrambles. So if anyone wants to like I always had one aspect of my golf game is always on, whether it be, if it's putting, then I can't drive. If I'm driving, then my short game is awful. So, but always one of them is on, which makes me awesome in golf scrambles. I have perfect pitch. I'm just bragging at this point. And I play 5 instruments, and despite my radio voice, I can sing. And then, I was thinking, if this whole medicine thing didn't work out, like Rock and Roll Jeopardy, when it was a thing, I destroyed everyone. Like, it was just demolished. I was a savant. It was amazing, actually. So anyway, that's where I'm coming from. So this is my DPC practice. And, this is one of the things that you'll see as you've done research, I'm sure, is that you need to have a website. At least these days, you have to have a website. And there's no really cool way to put a website on on here with a hyperlink. And so this is my website. Feel free to click it. I think it is hyperlinked. If not, I'll actually pull it up here in a second. But you know, I started in January. I didn't have my first patient until February 15th. And I'll tell you more about that in a second. It's just me. Now, I do have a part-time nurse that happens to be my longtime girlfriend, and she helps me out a little bit, but for the most part, it's me doing everything. And I got to tell you, it is refreshing to do that. So it is both family medicine and sports medicine. If you have gone over to my website, you'll see that there's two ways to sign up to my practice. And that speaks to how direct primary care is still very malleable. You can make it into the kind of practice that you want it to be. There are definitely hybrids out there that do, you know, partial fee for service and then have the membership side of things, and that's sticky. That's very sticky. In fact, I'll tell you how I do things here at the end. I have 2 rooms. I sublease 2 rooms, and again, that's about connections. I ended up leasing from a guy that does the radiology for the Rays, and it was just serendipity. When I went to go see the rooms, he was sitting behind the desk, and I'm like, "What are you doing here?" He's like, "What are you doing here?" And I said, "I want to rent these rooms." And he's like, "Well, we're not looking for like derelicts." He's still in here, rent the rooms, which is nice. So, you know, the question that's always begged is, why did you leave corporate medicine? Like the group that I was with, like I was entrenched. I was the chair of their physician advocacy committee or physician advisory committee. I was the first board member of the entire organization. And what I found was there was a swaying from supporting the physicians to emphasizing getting the box checked and getting the metric met and making sure that numbers were satisfied. And I thought to myself, I trained way too long and worked way too hard to be a data collector. And so I decided that I had to make a decision. And I'm 45. I know, right? But I didn't want to be like 50 or 55 and say, I'm stuck. You know, I have too much invested in this employed position. And after a while, morally and ethically, it became very distasteful what was being asked for me to do in, you know, running through patients the way that it was being run. People were just being seen. I think people want to be cared for. And so I think that that's the crux of direct primary care. And personally, one of the major reasons why I decided to go down that route. So what is direct primary care? Again, you've probably done some research, but I'm just going to go through this. This is the most succinct explanation of what direct primary care was for me. The exchange of primary care services for a flat membership fee. That's it. Like you can dress it any way you want to, with it, you know, having extra fees for whatever, freezing off warts or, you know, any kind of other services that you feel like are outside of what's necessary for access. But ultimately, that's it. And so there's no third-party payers, no government payers. You know, even specialists in my hometown here are like, so wait, what do you do with your Medicare patients? Well, it's the same. It doesn't matter. That I don't care what people's insurances are. Idealistically, I mean, realistically, I do pay attention to their type of insurance. If they have a high deductible plan or if they have an HSA, that's always favorable, all things being equal. So, but ultimately, I feel like DPC came about and this whole false economy, if you will, came about because of these issues, because of the Washington cartoon here of doctors having more than just the patient in the exam room. Anytime that there was you know, as the medical industrial complex got bigger and bigger and bigger. So, and you can substitute for insurance companies, pharmaceutical companies, and the PBMs, the in-betweens, the Optums, you can even put the government getting in the way of your ability to do what's right for patients. So I'm going to take 2 seconds. Oh, shoot, I've still got more on this slide. So a little bit more about DPC. It was defined in the Affordable Care Act, or Obamacare, to an extent. It was just put out there and there was a definition, but it was still very, very vague. And it was ultimately left up to the states to have some interpretation of how to handle direct primary care. And 23 states have DPC laws, including Florida. And if we can toot our own horn for a second, the FAFP was instrumental in getting the law passed 3 years ago that makes it so that DPC doctors are not considered to be insurance products. And you say, that's dumb. How is this practice anything like, Cigna or Blue Cross Blue Shield or United Healthcare? It's not. However, it was initially skewed to be where if you were being paid directly, then you were holding that money in retainer and using it for the patient's healthcare. That was absolutely incorrect. Ultimately, what the law in Florida does is it makes it so that direct primary care practices are not under the auspices of the insurance regulators, because otherwise there would be so many other things that I would have to hoops to jump through in order to meet those regulation requirements in practice medicine. So that's the short version. So let's talk a little bit about direct primary care versus concierge. I get this all the time. By the way, Jennifer, if people come on, do I need to just admit them, or
Got him.
Are you doing that?
I'm bringing him in. Yep.
You're doing it. Okay, good. So let's talk about DPC versus concierge. And this is almost a talk in itself. And so whereas DPC is a flat fee, either monthly or quarterly or even yearly for primary care services, concierge is where you have a practice that still submits fees to the insurance company, but charges an extra fee for those services that are not covered by that patient's insurance. And so anything that is considered to be outside of the realm of what is covered by that person's insurance, whether it be Medicare or private insurance, that fee then covers the physician's, gives value for what the physician does. So whether it be phone calls or even telemedicine, these are the kind of things that insurance companies don't pay for. And so you're still, my personal opinion here is that you're still tied to the insurance companies. You still have to go through and meet all of their metrics if you have any kind of pay for performance components in your contract. And so you're not free. You're still bound to the insurance companies. Now, that being said, essentially the patient pays $5,000 a year to have that doc's cell phone number. That allows you to decrease your patient panel to concierge usually has about 1,000 to 1,200 patients. So, but that's the main difference, is that you pay that extra fee, but you're still doing insurance. And patients are paying that extra fee for presumably better access to the doc. So DPC versus fee for service. So for the residents on the call, you get a glimpse of what fee for service is. You see some patients that are they're insured or they have Medicaid, if it's and you submit your bill within 90 days, you get paid at a certain negotiated rate for the services that you provide. And DPC is couldn't be any different, actually. And I think I have a nice little picture of this. Hold on. Let's go back to value-based care. Now, hold on. So rewind. So fee for service is ultimately what we had for the longest time, where you provide a service, the patient or the patient's insurance company pays for that service. Value-based care is a cool thing these days, kind of, where the idea is that payment is at least partially based on quality, and as opposed to seeing any more and more patients. With fee-for-service, your incentive is to see as many patients as possible, because the more patients you see, the better you get paid. With value-based care, it has a component of seeing a number of patients, but what you do with the patient also plays into your to how you're paid, which, I would argue that a lot of docs don't necessarily need to be incentivized to do the right thing for patients. But hey, this all sounded really good 10 years ago or 15 years ago, because the premise was that they would decrease the price of care. You wouldn't have to see as many patients. You'd be paid for doing the right thing. Then, this is my opinion, the problem with value-based care is that it's based on faulty metrics and things that are tough to measure. So the classic is patient satisfaction. So patient satisfaction is based off of how that patient is feeling at the time about what you are doing, and you financially tie it in to those scores. So your Press Ganey scores and whatnot. And in addition, the quality of what you are doing as a physician does not necessarily reflect on how the patient's numbers come out. And so it's a great idealistic premise, but faulty, unfortunately, at its core, in my opinion. So, and then this is the new cool thing. And so hopefully, I'm actually hoping that you guys don't understand this slide, because it is very involved, and it has a number of financial concepts in it. But the idea here, and I'll just pare it down, is that now there are front-end and back-end risk contracts. So accountable care organizations and clinically integrated networks are when groups come together and they say, hey, based on Medicare numbers, it costs about this much to do this, this, and this. We're going to try and do it 5% better. And if we make that 5%, then we get to keep all of it. Okay. And then, we're talking like millions of dollars for these larger organizations. And so there's a lot of pressure to get physicians to work together and really pay attention to what things cost. And this is in a fee-for-service land. And so you can see, I think that this little graph does show where there's the potential. But what's lost on a lot of this stuff is, and this won't be the last time you hear this, physician autonomy to do the right thing for the patient when the patient needs it. So anyway, I'll give you a second to do a screenshot so you can study this later. So why now? Why is DPC like a cool thing to do? It's when I was a resident, that was not the thing at all. The DPC was just a twinkle in Lee Gross's eye, and so DPC is so unpopular now because we're seeing the swinging of the pendulum back from employed physicians. So employed physicians are seeing that it's not the nirvana that it was promised to be, and physicians that are not totally entrenched are looking for ways out. In fact, if you're on Med Twitter at all, it seems like every other thing is, how do I get out of clinical practice? Especially for those that are in primary care. And so DPC is one of those ways that they can do that. Burnout. And, I hate using that term because it is overused and is so widely used. But I'm just going to put it there because for those that fall under that umbrella, it's not just, the setting that they're in. It is the constant drinking out of the fire hose. It is the clear inequalities in who is able to get what kind of healthcare when. And so DPC is a way to at least take back some of that control that leads to, or one of the many factors that can lead to burnout.
Hello?
So, too many bureaucratic tasks, and I'll actually look at the chat box here after this slide. So too many bureaucratic tasks, and it's just amazing what's asked of you once you get into private practice and you work for a large corporation. Just paperwork after paperwork after paperwork. I was averaging like 2 hours of paperwork per night. and that is wacko. That's not what I went to school for. And so that's even though it seems awfully trite, it's actually true. Clicks are death. So I would say this to our IT people all the time. Like, you're asking me to do 26 clicks to do this one task. Know that that you're killing me. This is murder, because clicks are death. The less clicks, the less time that I have to spend doing something that should be kind of either inherently or innately easy to do. And EMRs, a lot of EMRs, whether it be Cerner or Epic or whoever, don't have a sensibility about how to do these tasks in an easy and streamlined, efficient way. They don't automate what is otherwise automatable, and you end up doing a lot of clicks. And when it comes to DPC, I control that, and so it is very freeing in that regard. So physicians get a loss of control of their own autonomy over time. And if you know what I mean by that, you are insightful beyond what I was when I was a resident or a student, because you don't actually realize that it's gone until it is gone, or it's fleeting, or it's leaving. And so anyway, that I think has inspired a lot of physicians to look at DPC, which allows them to regain control. So I want you to say this with me. We'll do a little kumbaya thing together where I can see you. And so if you don't say it, I will be mildly annoyed. So say this with me. There is an inherent autonomy to being a physician. We're going to do it again. There is an inherent autonomy to being a physician. One last time for the people in the back. There's an inherent autonomy to being a physician. And here's the thing. People lose sight of that. And so when you have an administrator telling you how much money you're losing for the organization, or you have a best practices person coming up to you and saying, you really should be doing this, this, and this. And you say, well, yeah, if I did that, then that patient would do poorly for one reason or another. Yeah, but we're really going to need you to do, okay. And then all of a sudden there's a financial incentive to fall in line with those best practices. Administrators lose sight of this, that there's an inherent autonomy to being a physician. You are the boss, especially a family physician. I'll go on record to say, when I walk into the room in the doctor's lounge, I'm the smartest person in the room. No doubt about it. Like the neurosurgeons, they don't treat diabetes. I'm going to go off on a tangent here for a second. The orthopods, they don't even admit their own patients, for goodness sake. So, and they're good at what they do, but heck, I can talk about what they do because I have learned about it. It's part of my my very wide spectrum of what medicine is all about for many, many ages. And so to hold down my autonomy at all is asking for patients to do worse. And so because of that inherent autonomy, I think physicians are looking in the mirror and saying, why am I letting this factor or this person or this administrator tell me how to be the best doctor I can be? I worked too hard to get to this point. All right, so let's hit pause for a second. And let's read some of these questions. All right, so from Kelsey, do you get paid by insurance or only the flat rate? And so I'll go ahead and answer that now. So with direct primary care, there's no insurance whatsoever. I will admit to you that I was scared a lot because, like, when I opted out of Medicare, I walked to the mailbox like 3 times. I was like, are we going to do this? Are we really going to do this? And what's funny is that Medicare does send you a letter like, are you sure? Like a couple of weeks after you opt out. And sure, if you don't answer, then it does. And so I don't get paid by insurance at all. I get paid by the flat rate. And when we get to a later slide, I'll actually go through in detail what I do. So, and then you feel like that there's a little patient accountability as well.
Yeah, that was a reference to the fee for service and the value-based care and everything.
Sure, understood. No doubt about it. if you ask the patient though, they're like, well, I have insurance. So, I would say when I was in the fee for service, I would say to patients all the time, it's the patient's responsibility to know their explanation of benefits. But after a while, you realize that explanation of benefits is super complex. I had a back surgery like 6 years ago, and thank God I was the chair of finance for the organization I was with, because I knew how to read the stuff. But if I wasn't, then and I got charged like $8,000 for anesthesia that I did not get. I didn't get any propofol, and it said on there $8,000 propofol, and so I was able to say I don't need to pay for that. So anyway, the point is that yes, there's accountability for the patient, but it is such a complex system. I would actually be a bit forgiving for the patients in that regard. And then from Teresa, would this work well for rural family medicine physicians that offer procedures including vaginal deliveries, C-sections, and colonoscopies? The answer is, in my opinion, yes. So, oh, for goodness sake. So my opinion is yes. And a lot of these DPC practices are in the Mountain West area where, they don't care about insurance. It's a flat rate. They've got patients. They say, look, this is what my rate is, and I'm not going to be ridiculous about it. I'm not going to charge $5,000 a month because that's not what this community will allow. So they take their, whatever it is, $50 a month and say, I'm not worried about insurance. If you need an invoice, sure, here it is. But we're seeing more and more of those practices pop up. And in fact, there's some insurance companies out there that don't actually cover primary care services, because the way that they look at it is, if you take your car in for an oil change, you don't use your car insurance, you pay for it. And so the idea there is, speaking of patient accountability, the patient needs to be accountable for trying to stay healthy. And so if they are paying for their primary care services in this monthly fee, then there's and they're getting the kind of care that you get with that's personalized care with direct primary care, then they will reap the benefits of being able to avoid the number of heart casts or the number of procedures that come with good primary care. So yes, it does. It is well received by rural family medicine docs. And then the question, malpractice. Definitely, I have malpractice. I paid malpractice. Now that's funny because my malpractice is definitely a lot less than what it was when I was employed, and I didn't pay for my malpractice there. That was a great thing about it. But it's like 1/3, and I'll get to it later on. And you say, well, why would your malpractice be less? Because you don't have big corporation standing behind you. It's because I spend more time with patients. There's less opportunities for errors, and the malpractice insurers know that doctors are rushed. They know that things are missed. And so when they pull out their risk sheet and go over things, they're like, all right, well, if you are averaging more than 15 patients a day or however many, then your risk of any kind of all type error, not just the fatality error, but the errors that can lead to a higher cost, goes up. And so they look at DPC docs that see, 3 to 10 patients a day, and they're like, all right, assuming that the doc is worth their metal, their risk goes down. And so my malpractice rates are super low. Anyway, so we talked about this. And then lastly, another reason that DPC is so popular is this chart, which you may have seen this before. It's old data. However, I like this chart. I have other charts that have more recent data, but the point remains the same, is that the number of total physicians has been at a very, very slow rate, whereas administrators have gone up significantly. And the other charts don't have this, which is the percent growth of US healthcare spending per capita. And you can see that the slope is going up, and it mimics the rate of growth of administrators. And so, this is the chart that defies the myth that physicians are the source of cost, increased cost in healthcare. whereas a lot of it is dealing with the increased bureaucracy of healthcare. And so because of that, doctors like, peace them out. I don't want to deal with any of that crap anymore. And guess what? I can do it cheaper for patients and not have to deal with worry about whether or not I'm going to get paid for it. All right, so I may lose a couple of you here, but just stay with me. So I will admit to you, like when I graduated from residency, I was like, I had some debt, and I was like, man, it's gonna be too expensive for me to go out on my own and just have like 6 to 12 months of not being accepted to insurance panels and just moonlighting and just starving for a bit. And so, I had this opportunity to join this employee practice, and I find that when it comes to being an employed physician, that this analogy holds true. Where this mouse, imagine that you're a mouse. Done. I've imagined myself that I'm a mouse, and I get hired to be an employed physician, which is a jar full of rice, and it's just great because they say to you, don't worry about the financials or the insurance. We'll take care of that. Just worry about taking care of patients. That was the promise. And so you got the rice. You were getting paid to do what you were supposed to do. You didn't have to worry about any of the administrative stuff. And then you got very comfortable. You got comfortable eating the rice. It didn't matter that the amount of rice was going down over time, and the frequency of when the rice was replenished decreased. And so you would just stay there and you would enjoy it. And one day you realize the jar runs out of rice and you can't control when or who's going to give you that rice. And so you're so far into that jar that you can't get out. And so the moral of the story of this fable here is that a lot of employed physicians will trade for that comfort and kind of put on the blinders and turn a blind eye to how the business is being run. They just figure it's sausage. They don't want to know how it's made. I'm going to go there and be 8 to 5 and don't bother me. I'm just going to see my patients. We may have all come across that attending at some point in our training. That it's just about just getting the job done. I got to see my 23 patients, and after that, peace. I don't know if anybody of you guys spend any time at the VA, but not to knock them, but that's a lot of times how it's like. That they have zero incentive to see more patients than are on their schedule, and when 4:30 hits, they're out. And it's not about how patients do or what's going on in their patients' lives. Again, it's about patients being seen than it is about patients being cared for. And so you trade control of that rice to corporations for the comfort. And more doctors are seeing that promise of corporate employment, of being able to just practice medicine and not worry about the other things that are components of practice. That's just not true. It was a fallacy. So let's talk about what's great about DPC. Actually, I'm going to answer a question about. So how'd you go about picking your office staff? Well, what I did is one day I woke up and I looked in the mirror. I'm like, you look good. And then I said, let's start working. And so I actually don't have any office staff at this point. There will be a day where I'll benefit from having an office manager, and I'll ideally have one that has some clinical training. As I said before, my current girlfriend has been helping me out a little bit, but she's a hospital nurse, but outside of that, she hasn't been helping me too much. And then Giselle also asked, are there any additional skills you would recommend for DPC, like functional med, guided ultrasound, So I'm sports medicine, so I'm trained in ultrasound, guided injections, and just overall sports medicine symptoms. Now, here's the thing is that I try and do as much as I can for patients. And so skin procedures all day long. I freeze whatever they want. If something looks atypical, dermablade's my friend. Definitely love those. I don't do a lot of GYN just because I'm male, and also because just the whole sports medicine bend of things. So I don't do a lot of procedures in that regard. But in general, people want you to be able to, be that kind of full functioning primary care physician. So, do I give Toradol injection, I have once, so intramuscular injections, which of course are easy, but I do have an ultrasound. I do think that ultrasound is becoming more and more the standard of care, and so it's on my to-do list to do some training in abdominal ultrasound, but musculoskeletal ultrasound has served me well for sure. So as far as alternative med and functional med, I will color your opinion and tell you that there is no such thing as alternative medicine, and there's no such thing as functional medicine, because it's all medicine. It either has a good amount of studies to back it up, or it doesn't. And so, like Chinese herbal medicine, that's all medicine, in my opinion. I think that if you see the label alternative or Eastern or whatever, then someone's trying to sell you something. Especially functional medicine, like that had such promise as far as the premise of getting to the foundation of the pathologic process in the setting of other physiologic processes. But if you step back and look at it, that's medicine. So I didn't feel like that functional medicine was anything more than what we were all trying to do. So anyway, I'd say that any extra time spent on that would be neutral as far as what you do in DPC. But that being said, I have more time to read. And, I had 3 patients in a row with early onset Alzheimer's, and that's a story in itself. And so they all came at me with like, these are studies, and like, what do you think about the Bresden protocol, and da da da. And I'm like, what's the Bresden protocol? And so what's great is that I have time now to stand on the foundation of knowledge base that I've accumulated over time, and take that further and be that trusted source of advice for them. And so I'll actually embellish on that later. Just a couple of questions before I move forward. Patrick said, was there a turning point in your career where you realized DPC was the choice for you? Yeah. So yeah, I think it was when an administrator came and met with me for my quarterly and told me that I was losing $500,000 a year for the organization. And I said, there's no way. I do inpatient, I do procedures, I have the most RVUs, WRVUs, I'm the top 10%. There's zero chance, because, and if that is the case, you guys are terrible businessmen. You should fire me right now, because why on earth would you keep someone that is losing so much money for the organization? So I did this. Don't do this. If you are getting employed, don't do this, because I probably should have been fired. But I kept a spreadsheet of every single code that I put out. I went to the hospital. I knew who was getting what surgery when. And so I knew what the costs were for that, for those surgeries and those procedures, whether it be colonoscopy or an MRI or whatever. And I kept an Excel spreadsheet because I'm nerdy like that and a little OCD. And so at 9 months went by and I did that. And so I took the worst 3 months, added it to make it a full year, and I had my yearly, and I said, I brought in $2.2 million in net revenue for the system. I showed them all my numbers, and I even took it out on a margin, because again, I was director of finance for 3 years, so I knew what our margin was with our insurance contracts. And I said, I brought in $2.2 million. Don't ever tell me that, because all you're doing is trying to make me feel bad for what I'm doing right now. So, right, it was at that point where I was just like, what am I doing? Like, why am I fighting these people? Why am I not doing this for myself? Because I think that I, have the knowledge base on how to do it. I think my heart's in the right place to do the right thing for patients. And frankly, this is what I trained to do, not to be a pencil pusher and have to defend myself all the time. So yeah, that was it. That was the turning point. So, Greg says, what is your work-life balance like? Well, right now it's freaking amazing, because I only have 95 patients. So but that being said, I have to invest in myself. When you are a small business owner, like if you stop working, that's the whole practice stopping working. And so I did, learn from others that it's not healthy to just be, go from 5 in the morning to 2 in the morning the next day, get 3 hours of sleep, and just keep on going. That patience is a virtue, and ultimately, physicians, in my opinion, undervalue what they bring to the table. And so it's one of those like field of dreams things where if you build it, they will come. So am I working longer hours now? I'm not. But do I enjoy it since I'm working for myself? Absolutely. No doubt about it. So that is, oops, I got it. Yeah, absolutely. I'm enjoying a lot more. So I'm going to stop at that one, and I'm going to I'm going to talk about DPC pros here. So decreased patient volume. I had over 2,200 patients with my former employer. And so usually DPC panels range from 200 to 600, with 400 kind of being in the middle. You have increased time with patients. My first appointment is always an hour. And that's for us to like really do the deep dive, find out what the patient's health goals actually are, set health goals, and make sure that they're aware of what how different is this from seeing your doctor once a year. Again, you're just meeting an insurance product at that point. You're not actually doing healthcare, in my opinion. We mentioned the decreased risk for errors and a decreased overhead. Like my overhead is really decided by me. When I was with my former employer, like they asked me to cut costs. I'm like, I don't know how much anything costs. I know how much everything costs right now. And that's a good thing, because whereas before, I think that there was just really no incentive to do that. And so, I'm trying to keep my overhead as low as 20% if I can. And so that's there's incentive there to be smart about it. With direct primary care, you can do it your own way. So there's plenty of physicians who have decided to do it the way that I'm doing it, where it's very kind of a pure DPC. Others have a very small membership practice, and they can't, it scares the crap out of them to opt out of Medicare, so they don't. And so, but there's many different ways that you can do it. And you're the boss. I mean, you say it again, there's an inherent autonomy to being a physician. And so DPC allows you to do this. I mean, it is literally about this. It's literally about having that face-to-face. I mean, we wear masks, but having that face-to-face with patients, and it's a lot less about this. How many times have you guys been stuck in front of a computer because if you don't get this stuff in there, then it doesn't get done. And poor documentation is the bane of every resident's existence, for sure. So I'm able to automate what's automatable. I do have the computer up, if only to give my patient their dashboard, because transparency is a big thing for me. And so that they can see this, and we can share and see exactly what I've got down for their past medical history, medications that they're on, the dosing and whatnot. And people seem to really like that. So they can say, you know what, that's not correct. I didn't have my gallbladder out when I was 5. It was actually when I was 8 or whatever. And that helps you a lot. So let's talk about what sucks about DPC. So what sucks about it, first and foremost, is that it's not widely accepted really yet. And so it's not in the public mindset that, hey, this is a real option for my healthcare. There's still the idea, I've got insurance, I need to go to some doc, insurance will dictate that anymore. So in addition, like I'm on 24/7. Now that wasn't a big deal for me because I did inpatient and I, took call when I was employed. So I was kind of on 24/7 anyway. Plus I'm a team doc for the Rays and I'm always on for them. So that's not a big deal for me to have that set up. You have to set boundaries with patients. Any DPC book you read, it's going to say like you have to set boundaries for one thing or another. And so, what other doctors are afraid of and what everyone's afraid of are those high utilizers that call you at 2 a.m. every night because they're worried about their Tylenol dose or whatever. And so that is essentially a myth. Like I have 0 high utilizers. The people that do DPC in my hometown don't have those. It's really just kind of a legendary thing, maybe even an urban myth. And so, and even still, like you set boundaries, and I would even argue you set boundaries for yourself. Now, you don't have to necessarily set boundaries for patients. You just say, these are my boundaries. and you make it clear. The Jedi mind trick that I use is I tell patients, you call me anytime you need me, do not hesitate to call. And so the mind trick there is, all right, I can call anytime when I need him. All right. And so if it does get improper, like that Tylenol dose or whatever, I can say, look, you called me at 2 a.m. I want you to tell me how this is an emergency comparatively. And so you have to be able to be a little bit of a, I'm never afraid of conflict. That doesn't bother me. And so for me to say, is this the deal? And so it usually takes once and then the message is received. So money, I make less money. And I probably will, I'll probably make more money as an employed physician. So I made about $350 to $450 a year as an employed physician, and that was like full go, doing everything. Those are my best years. When I'm full, I mean, you can do the math. We'll do the math here in a second. And so for DPC, it's probably going to be more like 200 a year, 250 a year. But here's the thing: you actually have time to use it. To use the money that you've earned, you can actually use it. So, which is kind of nice. And then sometimes you have to take those extra steps for patients without insurance, which I will tell you, I will do that gladly. If you get on the Facebook groups, there's something called a DPC moment. And those DPC moments ultimately are where you make it happen. I had a patient 2 months into practice, 50-year-old, he was a budding diabetic, smoked, overweight, high cholesterol, didn't go to the doctor very often, was a drummer in a band, and he signed up. And he called me like 2 weeks in, was like Saturday, it was a Saturday night. He's like, my neck was really hurting me. And I had a hard time lifting my beer. And I was like, okay. I actually went to his house because it was on the way back from where I was going. And I checked it out. I'm like, you have a droop, dude. And so this was on a Monday. I got the MRI on Tuesday, cash-based, because I have connections now on where I can get it for $350. He had insurance. His copay was over $1,500. He did not have $1,500. And so I took that extra step. Sure enough, he had a ischemic stroke. And I got an echo for cheap. The only thing that was expensive was a cardiology consult. And so we got him into PT and speech therapy, and he's back to drumming now. And it's only been 6 months. Here's the thing: if I sent him to the emergency room, that's $10,000 right away, right? And then he's probably hospitalized, and he has the kind of high deductible insurance that it was something ridiculous like $15,000. He didn't have $15,000, so I did it when we figured it all out. I did it for less than $2,000. Yeah, and so, but you have to take those extra steps for patients. So. And here's what gets me, there's a little bit of guilt here because there is a PCP shortage and there are a lot of patients that don't have PCPs. You notice that my patient panel is a lot less. And so there's, a lot of patients that you can say are being neglected. The counter argument to that is I'm still practicing. And so I'm going to continue practicing in this instead of like practicing for maybe 5 more years in an employed type of situation and getting burnt out. I'm going to stick around for longer. So as far as like patients' lives that are being covered, it's about a wash, but we need more docs to go into DPC to kind of say that. And it's scary, man. Like you're doing this on your own, and you stand on the shoulders of giants, and there's resources everywhere. But I still lose sleep about it. I go in with a large amount of confidence, and I have no doubt that I will succeed. But at the same time, you're like, okay, this is me. And I don't have that kind of safety net that a lot of times is there. So here's my take. There's 3 things that DPC brings to primary care that are missing. One is access. You can get me by phone, you can get me by email, you can get me by text, you can get me by telemedicine, you can come into the practice. And so patients are reassured, and heck, half of them say that that's half the value for or all the value for the monthly payment that they make is being able to get to me. Transparency. So I'm upfront about everything, all of my costs, where I am. I had a conference. I'm going to a conference this weekend. And so I tell patients, hey, I have the ability to email everyone on my EMR and say, hey, here's my coverage. And just so you know, And I think that counts as far as creating that and maintaining that relationship. And then trust. You know, they're not seeing some random provider. They're seeing they're not seeing they're not seeing someone just to be seen. Like, this is someone who is a DPC doc, has demonstrated that there's care involved. And I think that is really missing in primary care these days, as much as we want it to be there. So I know I'm running out of time, so we'll talk about a DPC practice. It's very scary, but doable. Read up beforehand. It takes about 6 months, I think, to make your business plan. And so you'll read up, you'll find, I mean, this is kind of your basic business plan for any business, and you know, write it out. I'm a big Excel guy, as you guys might have picked up. So, you know, doing an 18-month business plan and money was not hard for me. Save up. So here's what's great about what I did. I had 13 years of me not buying Maseratis, of you know, saving money up, that I could say, okay, I'm going to spend, I would put aside $60,000 to start this practice. I have not needed $60,000. Let me just say that, but it's there, and I've been able to save up. You can also do business line of credit. You can do business loans, and those are, you know, very viable ways. I'm forgetting one. Oh, moonlighting. Like, some docs will moonlight while they're setting things up, and that you know, decreases the amount of money that they have to put up front. You know, you set up your team, accountant, financial advisor. You know, if you do start with another doc, sometimes DPC docs will start a practice 2 at a time. I think the biggest part here is that there are so many voices out there saying you have to be an employed physician because it's too scary. You know, people, you'll hear the times where the businesses fail and whatnot. And so, yes, you do need to be smart about shooting your shot, but at the same time, you can do it. And most docs, I think, can. And so you say, you know, so I'm moving a little quickly here, but when it comes to the money, it's very simple. Number of patients times your monthly rate minus your overhead, that's your salary. So right now I have 95 patients, let's just say 100. My monthly rate is for kids 5 to 18, it's $50 a month. For 19 to 39, it's $100 a month. 40 and above, it's $150 a month. And you're like, wow, that's more expensive than other things that you've read. That's because I don't nickel and dime. Everything's included. You need me to take out your hangnail? That's included. You need me to you know, do an EKG? That's included. You need me to freeze something off? Love freezing things off. That's included. Nothing is outside of what I'm doing outside of inpatient care. So if you're admitted to the hospital, it's $500 for the first day, $100 a day after that, and that's it. So, and again, on my website, boom, it's right there, and it's very transparent. So I know that if I'm averaging $100 a month, and I have 100 patients, that's $10,000, and it costs right now, whatever, $5,000 to run this office. My salary is $5,000 a month, which isn't great. That's $60,000 a year, right? But you can see how things can change as you can grow. You know, number of patients goes up to, say, 200. My monthly rate is, let's just say, on average 100. That's $20,000 minus my overhead, which I get down a little bit. I'm able to get that down to $4,000. All of a sudden, I'm making $16,000 a month, which times 12, that involves math, is, you know, $180,000 or so, which is respectable, right? And so once you get up, and you know, you're going to get to the point where, you know, if you really want to push the pedal to the floor, you can. But I'm not about that. So that's not where I'm coming from. I just want to, you know, treat patients well and be valued for what I do. The caveat is that I'm also doing sports medicine. So I do sports medicine, I take referrals from other patients, and I like to say that my sports medicine practice supports my primary care habit for now. And so I do, I'm trained in bone marrow aspirate and stem cell treatments, as well as PRPs. And those are high dollar things that I do. And so I do those, you know, 2 or 3 of those a month. And that does allow for me to cushion my revenue. And as long as we're being truthful, because we're all friends here, right? We're all friends. Yeah, good. I didn't do any marketing this year because I knew, as a president of the Florida Academy, I'd have to put a lot of time towards that, and it hasn't. And I was pulled in many different directions. So I did not push my growth. Now, I will tell you that my Excel sheet said that I needed to be at 150 patients by 18 months. And so being at 95 without doing anything is actually ahead of pace. So I'm doing okay, yeah, as far as that goes. And actually most people that go into DPC have that same experience. So keeping it small is key. That'll keep your overhead down. And the hardest part is really the legal stuff, just making sure all your ducks in a row. I hired an employment lawyer, best money. That was the best money I spent outside of an accountant. Like the accountant was good for getting things set up, but an employment lawyer really helped me get started. You know, some people do labs as part of their practice. Some people do radiology as part of their practice. I decide not to because there's so many opportunities and that are cheap around town that I can refer people to. Some people dispense medications in their practice. I haven't yet. I plan to at some point, but I just haven't had time to do that. And another stat here is that average time to full panel is about 20 months. So just to give you a level of expectation, like if your goal is 600 patients, it takes about 3 years. So one business takeaway that I think is worth pointing out here is value is tantamount to being a DPC physician. Most patients that you're going to have will have insurance. And so it should never be lost on you that patients with insurance are paying beyond their premiums to have you as their physician. And you know, I espouse that value proposition a lot. And guess what? I go and they think it's just above and beyond. And all the feedback I've gotten has been very positive. So I know that it is almost 8 o'clock. It's 8 o'clock now. Holy cow! I can talk a lot. So a couple things. If you're really considering DPC, you can do this. It's not one of those things where, well, if I can do it, then you can do it. I think any family physician that is, you know, trained the way that most, if not all of us are, sees DPC as a way to use that training in the most effective way possible of all the choices for being a physician in the outside world. And here's the thing, like if you want to get super idealistic about things, you know, I talk to med students, I talk to residents all the time, and I say, you know, you always try and shoot for that dream. You move in the, I think it was Henry David Thoreau maybe, or Whitman, I don't know. He said, move in the direction that your dreams are, move in the direction of your dreams is what it is. So you don't necessarily have to chase your dreams, just move in that direction. And so being the family physician that you've always imagined that you were meant to be, I think DPC is a way for you to do that. And so at the risk of being bold, just beware the siren song of employment contracts. They aren't what they used to be. You know, it used to be that that they would pay you handsomely for 2 years to use their hospital, and then you got out on your own and you did your own thing. That's not how it is now. Now it's they dictate everything to you. All medicine is local. When you set up your DPC practice, you use all of your local resources. It's the people that you know. Oh, someone asked about like what's something that was helpful. I did Leadership St. Pete. I did. It's through your Chamber of Commerce. Best thing I've ever done. Because Leadership St. Pete or Leadership, whatever city you're in, is a program that is through your Chamber of Commerce that allows you to be civically involved and see what your city is all about. And you make a lot of good business connections. I was the only doctor there, and you most likely will be as well. But I swear that that has been amazing as far as, and it's paying off so many dividends in my DPC practice now. And I would argue, and this is the topic, this is healthcare reform. So you making the change towards focusing on care for the patient as opposed to just having the patient be seen. That is the spirit of the healthcare reform that you know, was put out through the ACA. That is my primer on DPC. So let me get to some of these questions. I know we're running over here. Work-life balance, we talked about that. What is my current patient size, panel size like from Matt? 95. So I'm shooting for 350 to 400. Just with sports medicine, I'll be able to, you know, have people come in and out. I do sports medicine a little differently in that it's a $125 consultation fee for that first visit, and then it's $25 a month for while I'm following that injury. Okay, and so some people just keep me on retainer. I had one guy say, so let me get this straight. So if I pay $25 a month, I have the team doc for the raise for any of my injuries? I'm like, yes. He says, why would I not do that? Yeah. So it's a little unorthodox, but at the same time, it seems to work. What scope services? So this is from Okalu. I'm so sorry if I'm destroying your name there. Perhaps you've addressed this before, but permit me to ask again, what scope services does the monthly patient payment cover? Does it cover things like labs, ancillary procedures, injections, counseling, energy spent on referrals? So I don't do labs, but if I do labs, it would be included. So most people have insurance, and so they use their insurance for labs, and it ultimately be sometimes their copay is usually pretty low for like the standard labs. And if they do need to have any specialty labs, like whatever copper level and stuff, whatever the people ask for, then a lot of times I will divert them to a cash pay lab that will do it for like $2 instead of the $200 that a lot of times they get a bill for. But everything else, like injections, counseling, phone calls, that's all part of the fee. And I will tell you that is awesome for me because I don't have to do any. My ledgers are very simple, and it's just a lot of headaches that I don't have to deal with. So Deanne says, is expansion a part of a DPC model if one has a very busy practice? Absolutely, no doubt about it. I plan to have a second doc. When I actually do push the pedal down, I'll be recruiting for a second physician. And there's a model for having a second physician where there's payment to Goodwill up front or throughout the first year for the second doc, but outside of that, it is up to that second doc to recruit patients. And a lot of times it's on the coattails of the first doc, but who cares? Because in the end, you want it to be the kind of thing where people can rely on your practice and have that good reputation. So what resources do you recommend to prepare or set up for DPC? So this book, love this book. This is the Farrago official guide to setting up a DPC practice. It's great. Atlas MD, their website has a guide for setting up a direct primary care practice for free. It's free. I printed the whole thing out because it has like lists and things of like, this is stuff you might want. This is stuff you might need. Atlas.md. And what's funny is that the first time that I interacted with them, I called the number, and Josh Umber, Dr. Josh Umber, is a doc out in, I think, Wichita, Kansas. He's the founder and is the main medical director. He answered the phone. I'm like, he says, "Hey, this is Josh." And I'm like, "Oh, any questions about one thing or another?" He's like, "Fine, that's good." And he said his name. I was like, "Wait, did you say your name was Josh? You're Josh?" He's like, "Yeah, I cover the phones like during the day." I'm like, wow. So anyway, the point is that this company seems to have the desire to just make DPC work. And the actual EMR itself is very affordable. The only thing they do a little different from other EMRs is that they take a percentage of your if you charge credit cards, which, by the way, I don't take cash. You have to sign up with your credit card before you can schedule anything. And then once your credit card's in there, I don't even worry about it because it's on there. I get a little notice if it doesn't go through, and I have an automated thing that goes to the patient's email and text them that says, "Hey, your credit card didn't work," and so you kind of automate what's otherwise automatable, because the point is that I don't want to worry about financials. I want to worry about being the best doctor that I can be, and so by minimizing it, I'm still valued for what I do, but why make it any harder than it has to be? So that's that. As expansion, what resources do you recommend? So Atlas and the book there. This was phenomenal. I'm glad that you guys liked it. So I run over. I'm terribly sorry about that. Other questions. Hopefully this is the whole goal of me doing this was to pique your interest for those that were curious. To see what my experience was after 8 months and how I'm doing with it. I'm so much happier than I ever was with being an employed physician. I feel like I'm doing what I was supposed to be doing, and I have that kind of relationship with patients that you read about when you were a student and a resident, and it's that much better overall. So, so I really appreciate everyone's time. Any other questions, you know, put it in the chat and I'll get to them quick here. But otherwise, you know, if there's no other questions, thank you for spending your evening with me, and we'll go from there. So one question: do you think starting a DPC out of is feasible immediately out of residency? And yes, I do. I think that I regret not doing. I wish this idea was around. This concept was around when I was coming out of residency, because I think that I would have been really motivated to do it. And so, you know, if you go to my website, my number, by the way, is my cell number. So if you want to talk about this, you want to text about it, then you know, I'd be happy to talk to anybody about this. Another question from David Tran: how would you recommend developing connections to allow for affordable labs, imaging operations, and consults? You call and ask, and they do it. They want your business, man. So there's no, they're not going to say no to your money. They're going to say, oh, you're the conduit to, they want to get the lowest price. You know, the invisible hand of capitalism works here. And they say, oh yeah, we want to, here's some script pads. Let's make it easy for you to send your cash pay patients to have your labs done. You know, when it comes to operations and consults, you know, they're still very firmly in the fee for service land. But you know, ultimately, you know, the patients that you get, the patients that they get from you, after a while, DPC docs have that reputation of these are people that are cared for, and it's not a BS consult for, you know 2-second syncope that a neurologist would get. You know what I mean? And so that's ultimately, I think, where I think. You know, operations and consults, there are some places in the country where it is, you know, transparent in their costs, but we're still kind of bound to, you know, meeting your deductible, and then anything beyond that is paid for by insurance. How do you deal with payment defaults from patients? Do you deny defaulters medical services? I don't have to, because I get the email and I send it off, and then I send them a text like right away. And I've only had to send a text twice on one patient. So embarrassed that they, you know, they just forgot. They, you know, their credit card changed for one reason or another, and they're like, "I'm so sorry," because in the end, they value you. They value your transparency, your access, your ability to care for them the way that you do. And so I don't think that that is really a major issue. And you can't be afraid to talk about money. I'm not afraid to talk about money with patients. I know my value, and so I stick with that. Can they still use insurance for operations and consults? Absolutely. So the only thing that they don't use insurance for is my fee. Everything else they can use insurance for without any kind of restriction. Now, you can, and I always tell people, you know, pick this out with your accountant. If they have a high deductible plan, they have an HSA, you can use your HSA to pay for fees. And people ask me for an invoice, and it's justified as medical services. A lot of insurance companies, HSAs, are very liberal in that regard. So they get that pre-tax benefit of using it. But a lot of people don't like to use their HSAs because it is kind of a glorified investment account. So, so anyway, just as an aside, that's one aspect that people do like to use their HSA for paying for my fees. Well, I'm 11 minutes over. 13 minutes over. I appreciate everyone's time. Thank you very much, and best of luck. Hopefully you guys learned something, or at least laughed a little bit at some of my jokes.
And thank you everyone again for joining us this evening. If you have any questions after the call, feel free to email me at jyoung@fafp.org, and I'll be happy and make sure that Dr. Gross gets your questions and we can get those answered for you.
Let me just answer David's real quick, if you don't mind. So David has one last question. Speaking of sitting on the shoulders of giants, do you have 2 or 3 pieces of advice to kick ass in life, either professionally or personally? Yes. First piece of advice is all they can say is no, and I'm calling security. Okay. I say that to myself a lot because I'm not afraid for people to say no to me about one thing or another. And for the most part, if I'm reasonable about it, then they're going to say yes. And then the second thing is, that oh, it just flew out of my head. That's the main one. I mean, that ultimately will open doors for you, is to just not be afraid to be turned away, because if whatever it is, the sports saying goes that the only shots that you don't make are the ones you don't take. So
Don't
great.
ask, you'll never know. That's right.
That's right. All right, guys. Well, have a good night. Thanks so much.
Thank you, everyone.